Okay, good evening. Welcome to a special session of American Head and Neck Society Virtual Tumor Board. I am Bob Akivi. I'm your host tonight. Greetings from New York City. It's a cloudy, rainy day in New York City, but I'm sure wherever you are, the weather is better. I'm very pleased to announce tonight we have a very special session. We are joined by our colleagues from the skull-based section to have our first joint session of International Virtual Tumor Board. We have an excellent panel. I would get out of the way and give the baton to Dr. John de Almeida, Dr. Danny Fliss, who would be the moderators for tonight. And before that, we just have a word from Dr. Ivan Al-Sayed, the chair of the skull-based section. Ivan?
All right, thank you. Hopefully everybody can hear me. I just wanted to acknowledge the hard work of Dr. de Almeida and Dr. Fliss for putting this together and thank them from the skull-based section. I'd like to thank everybody for coming. This conference represents a new initiative from the skull-based section, and our goal is to create a quarterly tumor board with representatives at the international level. We really wanted to increase the interaction among the community of skull-based surgeons and those who treat cancer of the skull base. And we recognize that the opinions and techniques across the globe may vary due to a variety of reasons, and that's what we're here to explore and to hear about. And so I really look forward to this first conference of what we hope to be a quarterly session. Thank you very much, and Dr. de Almeida and Dr. Fliss, on to you.
Thanks, Dr. El-Sayed. So I have the pleasure of moderating this session with Dr. Dan Fliss, who joins us in the wee hours of the morning in Israel. And we have really a wonderful panel. But first of all, thanks to Babak and the Curriculum Development Service, Michael and Arnaud, for helping us integrate this into the workflow of their sessions. We have a pretty jam-packed panel, but a very distinguished group of speakers who Dr. Fliss will introduce.
Okay, so thank you very much, Ivan and Babak, for this nice introduction and for inviting me to this important academic event. In Tel Aviv, as I said before, is now 1 a.m. The situation here is getting better. We're now around 60% double vaccinated and around 80% once vaccinated. So life is trying to return to some kind of normality after this crazy and terrible year. Let me go straight ahead and present to you our excellent faculty for this webinar. These are all old skull-based warriors, as I said. We're in the Middle East, aren't we? And we've known each other for many, many years. So it is my honor and pleasure to introduce to you Ricardo Carao. Dr. Carao is an otolaryngologist and head and neck surgeon. His clinical and research interests are in head and neck oncology, swallowing disorder, salivary gland, cellular endoscopy, endoscopic sinus surgery, and open and endoscopic skull-based surgery. He is now at the Ohio State Department of Otolaryngology from 2011 as a tenured professor, director of the Comprehensive Skull-Based Surgery Program, and co-director of the Anatomy Laboratory toward Visual Spatial Innovation in Otolaryngology and Neurosurgery. His research interests are surgical training, surgical simulators, surgical anatomy, telemedicine, and development of endonasal reconstructive technique. He is author of more than 150 publications, book chapters, and he's a regular invited speaker at important head and neck and skull-based meetings, and an honorary member of many international societies. Thank you, Ricardo, for joining us. Now we'll move on to Piero Nicolai, my dear friend, which is a professor at the University of Padua now in northern Italy since 2019. And he's also the chairman of the otolaryngology department at the University of Padua. Piero Nicolai is known all over the world for his work in the skull-based region. He's got more than 250 publications in national and international journals, many chapters in books, and he is also the co-author of 3 books. He is member of many Italian and international societies. He sits on the editorial board of many professional journals, and he's been a visiting professor to either Memorial Sloan Kettering, MD Anderson, University of Pennsylvania, and the Mayo Foundation. And the third person which I'm going to introduce is Professor Sandro Procedo, our friend from Australia. He obtained his Bachelor of Medicine at the Monash University. He is an oncologist. He trained at Monash Medical Center and Peter MacCallum Cancer Center. In 2004, he joined the Princess Alexandra Hospital as consultant. And he now holds the appointment as Director of Radiation Oncology Research at Princess Alexandra Hospital and Professor of Medicine at University of Queensland. Professor Procedo runs an active clinical and translational program involving phase 1, 2, and 3 trials. He's published also more than 150 clinical research articles in leading publications, and he is a regular invited speaker at national and international conferences, including the American Society of Clinical Oncology, European Society of Medical Oncology, and so on. With that, I will handle the other 2 presentations to John de Almeida.
Thanks, Dan.
Hey,
We just have a couple of quick introductions for Doctors Cohen and you. Dr. Cohen is a good friend, skull-base surgeon at Memorial Sloan Kettering, and Dr. Yu, also a good friend and radiologist at Princess Margaret University Health Network. Unfortunately, Dr. Chan, Jimmy Chan, couldn't join us, and we're still waiting for Dr. Porchedo to hopefully log in. But just to move along with
John, can you speak up a little bit? I can barely,
just froze now.
barely hear.
Can you hear me? Okay.
Yes, but can you speak a little bit louder?
Sure. Sorry.
Great, thanks.
Looks like Dr. Porchedo has joined us. So let's get started with the cases. So the first patient is a 60-year-old female who presented to us with left-sided obstruction for 2 months, some epistaxis, and left-sided epiphora. She's quite healthy otherwise, no significant other medical issues. When we examined her in clinic, you can actually see a mass bulging out of her anterior nasal cavity on rhinoscopy, and certainly you can confirm that with endoscopy. On endoscopic exam, it sort of bulges to the contralateral side. She has epiphora on examination, and her trigeminal nerve is intact. We did a biopsy in the clinic, which showed a non-keratinizing squamous cell carcinoma that was P16 negative. Dr. Cohen, is this important? I mean, we know in oropharyngeal cancers, this has a prognostic impact. What is the importance of this in sinonasal squamous cell carcinoma?
P16 status seems to be ambiguous, although there's more data now that perhaps it portends a better prognosis. I think there's been a number of single institution studies. I think one out of Miami, Dr. Sargi and his group showed that P16 positive patients do better. There's been a few NCDB studies. I think Dr. Givey also wrote an NCDB study looking at this, and there's perhaps an improved outcome, but there's never been anything prospective. So we don't treat patients better or differently based on their P16 status.
Right, and so just to reiterate, there's an early suggestion that perhaps P16 positive or HPV positive sinonasal squamous cell carcinomas do better. And here's one of many retrospective studies. There's also data in the NCDB that supports that.
Actually,
So,
actually in the literature, there are about 20 to 25% of these tumors are HPV positive. Most of them are non-keratinizing, and they seem to have a better prognosis.
So we got an MRI on this patient, and Dr. Yu is kind enough to sort of be my radiologist, and he's here to interpret this. Eugene, can you tell us what you see here?
Yeah, John. So these are coronal MRI images through the nasal cavity. And you can see the heterogeneous mass filling the left nasal cavity, but also bulging across midline on superior line on the right. It extends right up to the level of the cribriform, and there's a little bit of remodeling of the left orbital, medial orbital wall. Yeah, so,
Further down.
yeah, this is the same thing, just a bit further back, just to show again, it's right up against the floor of the anterior cranial fossa. And again, some remodeling on the left medial orbital wall there, and nothing in the cavernous sinus, so nothing going back along any nerves. And this is the same thing. Again, this is just an axial series, the same through the sinus cavity. Again, just showing a broad lobulation, broad remodeling of the periorbita on the left. So no actual periorbital breach. And the CT scan, again, just shows dehiscence. The cribriform plates, you can see, are dehisced. There's marked thinning of that medial orbital wall on the left. But again, still, we see this commonly, and it's still compatible with an intact periorbita.
Great, thanks. So maybe what we'll do is we're gonna do some rapid fire just to get every perspectives from people across the globe. We're gonna, if you could just tell us what you would do and how you do it in maybe 2 lines. We're gonna go across the panel. Dr. Nikolai, what would you do in Padova?
Okay, based on the diagnosis, we would place this tumor among the high-grade tumors, and based on the experience we had with the National Cancer Institute in Milano, where together we performed a study that is going to be published, and we have been treating these patients with induction chemotherapy with a triplet of TPF, and we start typically with 2 cycles of induction chemotherapy. If we have a response which is more than 50%, we go ahead with the 3rd cycle. And if we have a good response, as I mentioned, based on the entity of the response, we go ahead with chemoradiation if we have a good response, or we go to surgery followed by radiotherapy if we don't have a good response, which means shrinking of the tumor, which is less than 50%.
Great. So it sounds like if it's induction followed by, in good responders, chemoradiation versus surgery in poor responders, correct?
Yeah. This is based on the fact that the category of poorly differentiated SCC is quite a heterogeneous group of tumor, and we know this about the changes in the molecular profile of the tumor. And the fact is that you can have a wide spectrum of response, which is ranging from a mild response to excellent response. And this is something that has to be explored in the future, the relationship between the molecular profile of the tumor and the entity of the response.
Piero, can you share with us some preliminary reports from the study?
Yeah, of course, based on the fact that, as I mentioned, we had not only squamous cell carcinoma, but we had also SNAC and SNEC within this group of patients. It's the results are quite variable. Of course, they are excellent with SNAC, not so good with SNEC, with the neuroendocrine carcinoma, and extremely variable within the category of poorly differentiated squamous cell carcinoma.
Dr. Crow, in Columbus, do this any differently?
Yes, a little bit. Is we do have the same protocol that we use for SNOC, and I do use it for squamous cell carcinoma when it's a significant invasion of the anterior cranial cavity or the orbit, if I want to reduce the chance of brain manipulation. But in this particular case, I would just go straight to surgery if the patient agrees to that, and then follow with either radiation or chemoradiation according to the extent of resection and the other characteristics of the tumor. I also offer the patient the possibility of just going ahead with the chemoradiation But in this particular case, my preference would be to take it out first and then proceed with adjuvant therapy. And among the radiation, we consider proton radiation. We discuss, even when we don't have it available in Columbus, we have it available close by, so we discuss the options with the patient.
Okay, Dr. Cohen?
So interesting. We would also offer an induction protocol with TPF is generally our process. Unless there was a CR, however, we would follow up induction with surgery generally. If there's a CR, then we would consolidate with chemo and protons. But if there was not a CR, we would do surgery. So certainly a bit similar to both the other folks.
Dr. Porchedu, in Brisbane, how would you handle this?
For an operable case such as this, we would operate and then follow up with post-operative radiotherapy plus or minus chemo. We tend to reserve induction chemotherapy or definitive chemoradiotherapy for our inoperable cases, or where we may feel that the surgery would require an orbital exenteration, in which case we would give either induction, particularly for the very poorly differentiated, such as described by Nikolai and Dan, but we'd give surgery and post-op radiation for this case.
Yeah, and for the audience, there is a clinical trial open that helps answer this question, led by Nabil Saba out of Emory University, Derek Lynn out of Boston, that randomizes patients in ECOG Akron trial, randomizing patients into an induction strategy versus surgery and radiation, looking to see particularly the skull base and orbit can be preserved. So in Princess Margaret in Toronto, our typical approach is with resectable disease. We do surgery and radiation. The Princess Margaret approach tends to be preoperative radiation followed by surgery, as opposed to surgery followed by post-op. And so we went ahead and did a endoscopic craniofacial resection. This is after radiation, 50 gray. We looked at the orbit to ensure no orbital invasion, and the typical endoscopic craniofacial approach here, where we identified the ethmoid superiorly and deal with these, skeletonize the skull base from lamina to lamina, frontal sinus down to planum, take down the crista galli. In this case, there was a little bit of dural enhancement, and there's always a question about microscopic spread into the nerves. So we did take dura and nerves and reconstructed with Duragen. In this case, we used a pericranial flap brought in through a small nasal root osteotomy for vascularized reconstruction. And I've tended to move away from this now. It avoids a cranie, but it's a small nasal root osteotomy. It's a big incision, obviously. So sometimes we'll actually use non-vascularized fascia lata and a multi-layer reconstruction. And this patient, of course, is treated with preoperative radiation, 50 gray given pre-op, followed by planned combined surgery. Dr. Porchedu, can you maybe speak briefly about the benefits of pre-op versus post-op, or vice versa?
Sure, John. There's no contemporary randomized studies looking at pre-op versus post-op. The proponents of preoperative really argue the case that you've got unperturbed tissue. It's easier to define your gross tumor volume. You use a lower dose of radiation treatment. The trade-off is that you run the risk that if there is a lack of response, you may convert an operable case to an inoperable case, or a case that requires a much larger operation, particularly if you've got disease, like this one right next to the lamina papyracea. In essence, the majority of people would probably use post-operative if you've got an operable case. There is some data from the Peking group in China, which I'm happy to share the reference, which did suggest that with preoperative, you had a greater complete resection rate. It jumped from 93% in the pre-op radiation arm versus 38% in the post-op.
Doctors Nikolai, would you do this entirely from below?
Yeah, of course. Exactly as you did it. Probably we would go directly with the multi-layer technique of reconstruction, because our experience is suggesting us that is quite safe in this specific case, and the percentage, the rate that we had of postoperative complications when you go to irradiate the patient was and has been very low. So the technique would be exactly the same as you show.
So I want to add a little bit about this. First of all, as Dr. Shah just his remarks right now on the screen, we proposed the same study as Piero Nicolai described before back in 2004. And at that time, it was probably too early for that. We proposed it for the North American Skull-Base Society, and I still have the documents. Anyhow, I think that this is the future. Regarding the reconstruction, I also reconstruct everything with fascia lata. And it works very nice in my hands. I've learned this from my tutor, Dr. Rave. And based on 250 cases, even more than this, I can tell you that the rate of complications by using this system is very low, as Piero said.
Would you do
Just a
reconstruction?
question to Rick. Rick, I know that it regards involvement of the orbit, not in this case, but in general. What is your philosophy in this regard? I know that you wrote several papers on this and you tried to write a meta-analysis. What is the point in which you sacrifice the eye?
I think that I have to see invasion through and through of the periorbita. Once you have invasion of the periorbita by a squamous cell carcinoma, then I think that I do tend to recommend exenteration. It's of course, it's very hard to follow margins or impossible to follow margins in fat. And once you have that type of invasion, also you would have to treat it postoperatively with direct radiation, which renders the eye more complicated in the post-op. So that's basically it. If the tumor is invading the bone, it's not a problem. If the tumor may be adjacent to the periorbita, is not a problem. Even minor invasion of the periorbita is acceptable. You can remove the periorbita, but once it goes through the periorbita itself, I think that all bets are off. And of course, it's more difficult as you move posteriorly into the apex of the orbit and closer to the optic nerve. Then it's a little bit more difficult to make decisions sometimes. But that's the basic concept.
So we don't have any evidence-based papers regarding this, right?
Exactly.
Unfortunately, we don't. Is for one, it's a rare event. It's a rare disease. It's difficult to gather enough numbers to have a valid data. And it's very difficult to randomize. It's what would be acceptable for some people may be unethical for some others. So it's unfortunately, this is a problem that we're not going to be able to answer for quite some time.
I should add that.
So we have a question from audience about the dural involvement in taking the dural. If the tumor approaches the dura, but there's no dural enhancement, would you take dura or you leave it? And I'll let John decide who wants to take the answer.
Well, why don't we ask Piero, Dr. Nicolai?
Yeah.
What would you do?
Whenever the tumor, this is something that we are checking intraoperatively, but we are quite extensive in our indications for resecting the dura, and then we can discuss if the dura has to be resected unilaterally or bilaterally. But our criteria is that although you don't have enhancement of the dura, but intraoperatively, when you go to the olfactory niche and you realize that the tumor is growing along the mucosa at that level, we take the dura. And then we decide if to go unilaterally or bilaterally according to the histology. I am thinking about olfactory neuroblastoma, for instance, or about the extent as assessed intraoperatively and obviously based on the MRI.
We wrote a paper on this topic. It's retrospective, where we looked at patients who radiographically had encroachment of the skull base with perhaps bony changes without any obvious dural nodularity, with and without dural resection. And there was an occult rate of dural positivity in cases where it encroaches the skull base. And, you know, we always are concerned also about the possibility of invasion through these little filaments, olfactory filaments, to get, you know, intradural. That's always a concern. Mark, Dr. Cohen, any thoughts on that? When do you consider resection of the dura?
I mean, generally, we obviously go a bit more than we expect. And based on your paper and learning from you, we typically will take dura if there's bone involvement. Obviously, things change based on intraoperative findings and frozen sections regarding the extent of the dural resection. But I echo your thoughts.
Dr. Crow, any differences in how you approach dural management of the dura and nerves?
No, not so much. It just depends also which part of the dura is affected. You can, for example, if you have more invasion laterally, not so much at the cruciform plate, you can think of the dura as periorbital. Therefore, is managed in the same way. If tumor is pushing it, there's no need to remove the dura, but that's kind of rare. Once it gets into the cruciform area, it's a little bit more difficult because of the nerves and the different little crevices and pits that the skull base contains. So I basically follow the same premises that have been discussed before. The old dictum of oncologic surgery is go one mesenchymal layer beyond the invasion of the tumor. So that's basically what we do. We do remove the dura.
Can I ask Dr. Yu regarding the enhancement of the dura? How much do you trust on imaging the enhancement of the dura? We all know that it has a high sensitivity, around 80%, but a very low specificity.
Yeah, that's true. So, the dura normally can actually enhance. So what we're looking for are other things. So is there any nodularity? Is there asymmetric fullness on one side or the other side directly underneath the tumor? Those would be things that would raise the bar more. If there's any changes in the overlying brain parenchyma, for example, if there's invasion actually into the olfactory bulbs, that would obviously be another level of invasion. But you're totally right. Like the dura is, if you call dura because it enhances, you're gonna call it all the time, and you're gonna have really poor specificity.
So this patient is now 7 years post-op. Her margins were clear at the time of surgery, and this is her post-operative imaging 10 years out. And she's disease-free. In fact, I've since discharged her from our practice. So
fantastic. John, you have 30 minutes to finish the last two cases.
Yes, thank you, Babak.
All right.
Some rapid.
The tumor board, Ivan has been here quite a few times, so it's a very fast case and fast pace. So it's like congressional hearing. Yes, no, move on. Let's go.
Well, we get stuff done here, Babak.
Let's see.
Speaking of which, yes, no questions. So we're going to go one by one, and the question is craniotomy or not. We'll start with Dr. Cohen. Olfactory neuroblastoma. You can see obviously some nerve involvement on the right with perhaps some invasion of the falx. Craniotomy, yes, no?
No.
So entirely endoscopically?
Entirely endoscopic.
Okay. Dr. Corral, olfactory neuroblastoma. Again, dural involvement and nerve involvement. Craniotomy, yes, no, based on this?
No, with a caveat. No, with the preparation to be a yes in the middle of the case if I cannot obtain the negative margin laterally in that orbit.
And can you tell us, like, what are your limits for getting lateral?
So usually it's about the equator of the orbit, or the basically mid portion of the orbital roof. You can remove the bone and displace the soft tissues of the orbit to get there. But if it is really, if the dura is really invaded in there, I want more margins than that. So that will determine really whether or not I'm gonna open it up. Nowadays, you can also obtain margins with an orbitotomy, and that would be another option. So again, answer no with an asterisk.
Can you technically describe what you do with an orbitotomy to get lateral access?
Yeah, so orbitotomy here is a regular orbitotomy. We're not talking about these new approaches that we have through the orbit. It's basically you do an incision on the upper eyelid, on the crease, and you dissect the roof of the orbit, and you can remove the roof of the orbit by just retracting the orbit down. So this is nothing extremely fancy, and then you have access to basically all that dura. So it will depend on how far back. It will depend again on your comfort doing that type of thing. But you can avoid the craniotomy, that at least in a craniotomy in the regular craniotomy fashion. It is a craniectomy, but you just do it through the orbit.
Thank you. Dr. Nicolai, craniotomy or no? This is a sinonasal biphenotypic sarcoma. Craniotomy, yes or no?
This is a different case. This is a sarcoma. So with sarcoma, we should obtain wider margin. So I would be very cautious to go only through the nose in this specific case. I would prepare the patient and I will get the patient consenting for a craniotomy, because here it's vital, in my opinion, to have wider margin compared to, would say, Hyams grade 1-2 esthesioneuroblastoma. So it's a case where I would be larger in the indication for craniotomy.
Thank you. And you know, you've published on this extensively, indications for an endoscopic and a nasal approach. I mean, there's obviously frontal sinus involvement here.
Yeah, of course. But here we have an invasion also of the orbit, a frank invasion of the orbit, at least.
Right. Are there any patients you would not do a craniotomy on with frontal sinus involvement? Are there any histologies that you would not do a craniotomy when you have invasion into the frontal sinus?
Okay, if I am confident in reaching the periphery of the tumor, especially if I am dealing with a low-grade tumor, let's think about intestinal type adenocarcinoma low-grade, or a minor salivary gland tumor low-grade, I would go also transnasally with a draft tree and using the technical details that Rick was alluding to, displacing the content of the orbit and obtaining as much space as I can. But differently, if I am not able to expose the entire periphery of the tumor, I would be always very cautious. But in this specific case, for low-grade tumors, could be a solution.
Piero, how about the anterior wall of the frontal sinus?
No, the anterior wall of the frontal sinus, if it is involved by the tumor, it's in my hand a contraindication for a purely endoscopic approach.
Right.
Okay, so maybe we'll move on. Babak tells me we've got half an hour to get through 2 cases. So this next patient is a 7-year-old lady with a recurrent nasopharyngeal carcinoma, originally treated with chemoradiation with adjuvant chemo 2 years prior, T2N1. She now presents with a biopsy-confirmed EBR-positive nasopharyngeal carcinoma, pretty healthy lady otherwise. And this is her imaging. Eugene, can you tell us what you see?
Yeah, so I'll keep it really short. So these are MRI images, and I don't know if you have control of the pointer. You can point to that little tumor that you right there. So that's like the smallest NPC that we see around here. So just a little tucked up in the fossa rosemuller.
Right.
So, Dr. Yu, can I ask you a question regarding this? This is a lady that underwent radiation therapy in this area. Can you tell us what are the changes? What do you expect to see after radiation therapy in this location?
Typically for NPCs, we might see some generalized edema of the mucosa. Usually, if there's a good response, we actually don't see the tumor anymore. You may see some scarring, so some black margins on, especially on the T2 weighted acquisition along the periphery. But that's usually about it. Maybe some changes in the bony skull base. We don't have any real images of that right now, but for example, on a T1 weighted acquisition, you'll see some gray intermediate signal within the skull base after therapy.
Treatment options. Maybe we'll start with Dr. Porchedu. Sandra, what would you do here?
So the treatment options are whether this is surgically resectable. That would be my preference. If that's not feasible or for whatever reason, then I would consider re-irradiation, but there are a number of factors that we need to take into account when considering re-irradiation. There is the systemic option, but this case is technically still curable, so I would still aim to obtain optimal local control.
And can you maybe speak briefly about, she's received 70 Gray to the area. What
Yes.
kind of dose fractionation, if you did, let's say your surgeon said, I can't resect this or I'm not comfortable. What are you thinking in terms of minimizing late toxicities? Obviously, she's a sitting duck in the re-irradiation setting. What would you do?
Yeah, so look, there are a number of things that I look at. The first is where the recurrence has recurred. Now, this case, thankfully, is not involving the clivus. Once you've got extensive clival recurrence, it's very hard to get any meaningful dose in a re-irradiated setting without compromising the brainstem. The second thing is that what we would do is look at what radiation treatment has been received. And then I go through the process of actually replanning the patient. And then there are a couple of organs at risk which are non-negotiable, such as your brainstem. So I won't exceed the brainstem dose. So I actually start, ideally, if I can re-irradiate to 60 to 70 Gray with concurrent chemo, and then I pull back the total dose until I get a safe brainstem overlap dose. It's also important in these cases to actually consider the biology of the disease. In other words, if you've got a recurrence that's recurred within a couple of years, then really you'd have to argue whether a further course of radiation is going to be useful at all. And if you look at all the re-irradiation series, one of the factors that comes out is early recurrence, they do poorly, later recurrence may do well. And all the others, and all the series that have looked at re-irradiation, there's about a 30% risk of significant grade 4/5 toxicity to organs at risk.
At Princess Margaret, our group tends to prefer a BID dosing, and you're probably very familiar with that in the re-irradiation setting. 44 Gray, I think, with BID dosing. Any thoughts or comments on that?
So that's a hyperfractionated treatment is an excellent idea. In reality, when I go to treat these, I normally end up treating about 40-45 Gray BD dose with weekly cisplatin if it's feasible. That's generally what you end up doing.
Okay. And to the surgeons, anyone would not operate on this? So it sounds like we have consensus. Everyone would operate. So we went ahead and did an endoscopic nasopharyngectomy. This is actually what I consider a landmark paper. We don't see these papers often. You know, a excellent question, an excellent trial published in Lancet Oncology in just a month ago. It was a phase 3 randomized trial, 100 patients per group, looking at endoscopic nasopharyngectomy in patients with T1 to T3 recurrent disease, with or without nodal metastases, versus radiation. And the radiation was delivered, as Dr. Porchedu mentioned, sort of 60 to 70 Gray. And these were the survival curves. They showed superiority of the patients treated with an endoscopic nasopharyngectomy approach overall and disease-free survival. Now, this is perhaps one of the most interesting things in the study. You can see the toxicities are exactly as we would expect, significant grade 3, 4, 5 toxicities. In fact, grade 5 toxicity, a toxicity from which someone dies, late toxicities, grade 5 in the surgical group 5% and 20% in the re-RT group. So high potential morbidity in this setting. And so, a very good paper, and I encourage everyone to read it and look carefully at it. There are obviously toxicities with surgery, and this is why I'm presenting this case. So we did an endoscopic nasopharyngectomy, and this is our 3-month. The margins were clear, close on the deep. In fact, we skeletonized the carotid. The tumor was deeper than the imaging would indicate, and this is often, the case. We got down sort of transpterygoid, which is our typical approach, take down the posterior maxillary sinus wall. And I often try to keep the medial pterygoid plate with our specimen, drilled through the pterygoid wedge, release the pterygoid musculature, and come through the torus tubarius. Often one of the challenging areas for resection is that pharyngobasilar fascia along the basis sphenoid, where the mucosa is very close to the bone, so it's hard to get a deep margin there often. And we got a close margin, but negative margins. And this is our post-treatment imaging 3 months post. Dr. Yu,
Yes.
what do you see here?
So John, so just focusing on the top panel, those are enhanced images. And the most striking thing is this broad band of enhancement across the midline and central aspects of the skull base. You can see enhancement actually of the bony structures, the clivus, C1. There's extension of the peripharyngeal space, encasement of both carotids with narrowing actually of the right carotid on the right side. And also near that carotid on the right, on the first image on the top, you can see an actual collection, a limb enhancing collection in that region as well.
Doctor, yeah, go ahead, Eugene.
Okay, so at that point, we were actually more suspicious of skull-base osteomyelitis. So at our place, at PMH, we do a bone scan, which is the top panel, a sulfur colloid scan, which is the panel highlighted with the yellow margins, and then a indium white cell scan. And so we do this to sort of confirm that this was a skull-base osteomyelitis, and based on these findings on the study, sort of positive bone scan, positive white cell scan, and a negative sulfur colloid, it tells us that it's compatible with a skull-base osteo.
Okay, so maybe Dr. Cohen, what would you do at this point? Patient has what we suspect. I mean, we're not sure that this is not a recurrence, but we suspect that this is a skull-base osteonecrosis. What do you do in this case?
Unfortunately, we see this not uncommonly, this scenario. I would start out based on that MRI scan with basically enhancement everywhere with broad IV antibiotics. The stakes are so high here that I would start with broad IV antibiotics. We don't tend to treat ORN very often at all at our place with hyperbarics, but we would definitely start with IV antibiotics and very aggressive monitoring. Unfortunately, Dr. Yu knows this more than I do, imaging lags behind, so you can't really follow imaging very well, but I would plan her for a long term of IV antibiotics using a PICC line.
Dr. Corral, would you do anything different? Would you consider a surgical debridement or anything like that in this case?
It depends on what I see in the endoscopy in the office. However, is one question I had is what did you use for the reconstruction?
We used the contralateral septal flap. We were able to lay it in there.
You have vascularized reconstruction on top of the carotid.
That's right. Yeah.
That would be important, because if you have that type of a scenario and you have reconstructed with some type of free graft that is gonna just melt away, then you have a high risk of a carotid rupture. Nonetheless, the nasoseptal flap is adequate, but it's thin, so I would follow it. If I have any question, I would go back and go and do mapping biopsies, make sure that we are not dealing with a carcinoma. Sometimes it's very difficult to distinguish one osteoradionecrosis from recurrence. I agree that in this case, it seems like it goes into the radiation effect more than a recurring carcinoma. And I would treat it just like it was discussed with antibiotics. I would use hyperbaric oxygen for the extent of radionecrosis that I see there, and follow the patient very closely.
Yeah, the point is that frequently you have both. You have the osteoradionecrosis and you have also persistent or recurrent cancer. And sometimes it's very difficult because you don't recognize the area which is corresponding to tumor. So you have to sample very extensively, although this is entailing the risk to expand the osteoradionecrosis. But in regards to the policy of treatment, long-term antibiotics, even in our experience, and I do agree that these cases are increasing in number. So we are seeing more and more frequently these cases.
Dr. Nicolai, your thoughts on hyperbaric oxygen when you're not certain about recurrent tumor? What are your thoughts?
We prefer not to go for hyperbaric oxygen therapy if we are very close to surgery and you had close margins, not to speak about positive margins, obviously.
Piero, I ask you, how about margins in surgery for recurrent nasopharyngeal cancer? What is your policy about that?
Okay, you know very well that in this specific case, in this specific area, there are no agreed upon margins because we don't have enough experience as in the sinonasal tract. But usually we consider a close margin when we have a margin of 3-4 millimeter. And we are usually considering the re-extension of the resection, because when we can, we obtain also a sample from the surgical bed, and we are precisely mapping also this extension of the resection in order to try to have a real margin to assess.
So
John, there's a question from audience for use of Trentol vitamin E, if you would like to bring up to the panel.
Yeah. So the evidence for osteonecrosis, pentaclo treatment, pentoxyphylline, vitamin E, clodronate, and sometimes with antibiotics. That's obviously the Delanian regimen for ORN that we use for mandible. Dr. Nicolai, thoughts?
We are using even the association of pentoxyphylline and vitamin E. Yeah.
Dr. Crow?
Sorry, we use it.
Dr. Cohen, use it? Yes, no?
Yeah, we don't, probably doesn't work, but we use it also.
Exactly.
Okay. So here's a study on the use of sequestrectomy in patients who have skull-base osteomyelitis after nasopharyngeal surgery. This is the biggest series I could find. They went in and did sequestrectomies. I'm sorry, let me.
No, that's not the one.
Yeah, let me advance here a little bit. And so they went on to do sequestrectomies. And what they found here is out of just over 50 patients, the severe hemorrhage rate and death from severe hemorrhage rate was 24 out of just over 50 patients. So, you know, a big series that from a single center where they went and managed this with sequestrectomy and further tissue. Obviously, what they did for reconstruction wasn't clearly stipulated, but a lot of catastrophic hemorrhages. And in this process that's so diffuse, it's not easily a straightforward decision-making process. But just thought I'd share that. So this lady, unfortunately, presented shortly after this. She was treated with antibiotics. We contemplated hyperbaric. We didn't do it because of the concern of tumor recurrence. And we did not get her to see the pentaclo treatment group, but she responded well to antibiotics, and then presented with hemiparesis. Dr. Yu, do you want to just tell us what you see here?
Yeah, so on this study, you can see that the patient developed infarcts up in the corona radiata on the left there, and then if you went back down a little bit, the patient actually occluded the left carotid artery. So there's a flow void at the base of the skull. Like they lost the skull.
So unfortunately, secondary to this process, contralateral to the side of the resection, occluded her carotid artery and developed an MCA territory infarct. She's been rehabilitated and getting better neurocognitively, but just speaks to sort of some of the challenges with this disease process, and whether it's surgery or radiation, certainly side effects can occur. So let's get on to our last case. I know we have about 10 minutes. Want to get the thoughts of the group on this case. It's a patient, 75-year-old lady, presented with a left-sided nasal mass with facial discomfort and paresthesias, some occasional epistaxis, and also some hearing loss on the left ear. She had on examination V2 numbness and a left nasal mass extending from the posterior lateral wall all the way to the anterior aspect of the nasopharynx, and a submucosal mass in the hard and soft palate junction. And I biopsied her in the clinic, and it showed an adenoid cystic carcinoma. This is her imaging. Dr. Yu?
What's subtype, John? What's subtype?
We don't often go by the solid cribriform tubular variants that have been described historically. Our pathologists tend to give us a grade on them, a low versus a high grade. And this one was reported as a low grade adenoid cystic carcinoma. Does that change things, Dr. Fliss? What subtype?
Well, yeah, well, we're still using the solid versus tubular and et cetera, et cetera. And we regard the solid type as the most aggressive one between the three subtypes. So we treat them accordingly.
Okay.
Johnny, I'll make a quick comment just about the subtypes. I think with adenoid cystic carcinoma, while they histologically may look low grade, it's really about their biological behavior that's most important. So if you've got a low grade looking ACC, but widespread perineural invasion, it doesn't matter what subtype it is. This is an aggressive ACC.
All right, good point. Dr. Yu, can you tell us what you see here?
Sure, John, just hold it right there. So you can see the enhancing lesion on the undersurface of the left hard palate. And then you see this broad swath of tumor extending anteriorly, so it's superiorly into the region of the pterygopalatine fossa and the infraorbital fissure. So that's right there. So you can actually see it's filling that pterygopalatine fossa. It's like perineural spread superiorly along the palatine nerves. And if you go to the axial, you actually see, if you keep going, you'll actually see, keep going.
So there's also clear invasion here. I know Dr. Yu doesn't have control of the Vidian nerve, which is enlarged here. It tends to taper out at the carotid genu, but invasion, clearly gross invasion of the Vidian nerve here.
Yeah, and there's also on the axial, we'll see that better. So there you can see the pterygopalatine disease, the Vidian disease. And as you follow it down, there's tumor tracking along not just the nerve canal, but also along the mucosa of the nasopharynx inferiorly.
And into the hard soft palate junction, likely tracking that palatine nerve, the greater palatine nerve. So maybe just sort of what we'll do, we'll go across the panel and then ask surgery or radiation here, starting with Dr. Cohen. Just surgery or radiation?
At the risk of getting tomatoes thrown at me, because I know the great work that's done in Brisbane and in Italy and Tel Aviv and in Columbus, I would radiate this with protons and chemotherapy.
Dr. Nicolai in Padova?
For this specific case, probably we would go for surgery, and I tell you what is the philosophy. If we can, for adenoid cystic carcinoma, if we can achieve a situation of R1, we go for surgery. If it is a situation where we know from the beginning that we will leave an R2 situation, macroscopic disease, we don't go for surgery. So in this case, we would go for surgery. Obviously, it's not the case to discuss about the reconstruction, and then we would consider which type of radiotherapy to go for as an adjuvant treatment. And based on the presence of or absence of a solid component, we would add chemotherapy or not.
Pierre, can I ask you a question regarding this? If the possibility of a near total resection comes out with close or positive margins, that's an R1, R2 with preservation of vital structure. Is this an option for surgery
I
in
would
case
say
of
that
adenoid,
I would say
especially when the part of the tumor is situated intracranially?
Yeah, if the tumor is going to the intracranially to the Meckel's cave, for instance, we would not go for surgery because there are some data concerning carbon ion radiotherapy, which are clearly shown that you have the same results and local control if you go for definitive treatment with the carbon ion compared to the cases that were operated and where residual tumor was left.
Dr. Crow, surgery or,
So,
or radiation?
It's meaningless.
Same as Dr. Nikolai. I would operate and then follow with adjuvant radiation.
And what would your approach be here?
I think that this patient needs a maxillectomy, followed by, and I would continue with an endoscopic assistance to follow the rest of the tumor in the skull base.
Dr.
Yeah.
Porchedu, what would your approach be here?
Yeah, so look, this is not for the faint-hearted, obviously, but it's really what the patient's willing to accept. This is a big operation, as you all know, but if the patient was agreeable, we'd offer surgery and post-operative radiotherapy. We would go in knowing that we're going to have positive margins, and then we would irradiate. I'll just make you aware that we have recently published our skull base experience with adenoid cystic carcinoma in oral oncology. Ben Panitz and myself, first author is Emily Guazzo. We had an 80% 5-year local control, and 80% of those with surgery and post-op rays, and 80% of those had a positive margin post-operatively.
So
Yeah.
this is amazing work. I mean, my only question is, as someone who's in her mid-late 70s, who's had this for many years, all the data is obviously retrospective, but data from Boston on protons, you could have 60 to 90% 10-year local control.
Yeah, Mark, I agree. This is not for the faint-hearted. You know, normally the ACCs like this are actually younger women.
Yeah.
In this patient, it'd probably be a little unacceptable. But, you know, if she was one of those 70-year-olds that walked in who was like super fit, you'd at least talk to her. Unfortunately, access to, you know, heavy ions and, you know, proton therapy is not widespread. And in our country, we don't have that. We'd have to, it would be a logistic. We can get it, but it's a pretty logistical, challenging process. So I guess some things are regional, and for sure, if I had easy access to protons, I'd probably, that would come up a little bit higher in selling radiation up front. But I agree with what you're saying.
I believe that another point which is very important coming from the results on carbon ion of the group from Heidelberg are those related to the toxicity. The toxicity was much higher in patients who had surgery before compared to patients that were treated with the radiation. So this is another argument when you know from the beginning that you will not achieve a resection with at least a macroscopic margin to go for only radiation therapy and not for surgery and radiation therapy. Once again, we are talking about retrospective studies and retrospective data.
Dr. Corral, if we know these nerves are going to be involved, we know that it's almost impossible to get an R0 resection here unless you, I mean, probably no matter what you do. What's your cutoff? If you see, you know, enhancement or enlargement of the nerve in rotundum or the median nerve like we see here, when do you say, okay, surgery is a no-go?
I think that what Dr. Nikolai gave you as a guideline is useful. If you think that you're going to leave macroscopic disease, I think that will be the cutoff. If you can achieve microscopic, you basically take out all the gross disease that you know you're living microscopic disease. I think that radiation therapy sterilizes that field fairly well. So I think that that's basically it. Is if you can take it out completely, everything that you see, I'll go for it. If I can't, then I stop and consider other options.
And any role to chase V2 into Meckel's cave?
Oh
Take
yes,
out
we do follow V2 into Meckel's cave, but it's again depends on the extent of what you see. If you see that the whole Meckel's cave is invaded, or you have invasion of the root of the trigeminal nerve going into the brainstem, you know you're not going to clear that in that way. So, but if you have V2 involvement like this patient had, and you can clear that involvement to microscopic margins, then it's okay. We go for it. And in the case of the Vidian, the limit will be the carotid. Once you go over the genu of the carotid, then it's very difficult to follow that nerve further back, and that will be my limit.
Okay, great. So, that's in fact what we did. We offered surgery. The patient was a physician from China, and she was actually keen on it. I think Dr. Cohen brought up some excellent points. We did carefully consider definitive radiotherapy on her, and ultimately, as a group, we decided R1, hoping for R1 resection with planned adjuvant. And there is some data with adenoid cystic that shows that the importance of surgery with respect to, oncologic outcomes. You can kind of see here when surgery is in the mix, there's definitely, a prognostic benefit. And this is data from the National Cancer Database. And surgery, certainly the importance of adjuvant radiation, no one would question that in this setting, as we know we're not going to achieve widely clear margins. Dr. Porchedo, do you want to touch a little bit on this slide on perineural?
Just very quickly, thank you, John. So look, from a radiation oncologist perspective, when planning these, you need to sit down with your neuroradiologist, your surgeon, to get it right. There hasn't been really good consensus on what are the volumes in this setting. So we've published a paper that's really a recipe book for radiation oncologists in designing the treatment, and it's based on what zones were affected. It provides a dose when using either 3D CRT, which very few use these days. It provides a dose for IMRT. So it's really from an educational point of view, putting in the plug to the radiation oncologist that this is a multidisciplinary planning process, and we've produced something that people can follow in terms of guidelines.
Thanks, Sandro. So we did what we discussed, and as Dr. Corral had explained, we actually did a planned combined approach. I came in endoscopically from above first to take the disease off the orbit and open the sphenoid, find the nerves. And then we did an infrastructure maxillectomy transorally. So this is some of that. We opened the sphenoid sort of bilaterally, drilling down the rostrum, just getting things widely open. You can see there's a posterior septectomy here. Now here we are coming through a Caldwell Luck. We're taking the bone off the lamina and some of the floor of the orbit. We tried to preserve a lot of the floor, and you can see the periorbita there. This is through a Caldwell Luck visualization. Now we're getting lateral access to the disease, taking down the posterior wall of the maxillary sinus. You can see we're getting into the pterygomaxillary or even buccal fat there, cauterizing that and getting access laterally to this. Taking bone further down, you can see sort of here, we're starting to see the pterygoid muscle exposed and some fat in the infratemporal fossa and pterygomaxillary fissure, which we're cauterizing. And you can see the orbit is just above us, the disease just below us. Here we're reducing some of the fat, and the tumor is on the suction. We've clipped here the internal maxillary artery to devascularize the tumor. And now we're separating the disease there. You can see going into rotundum, the V2 nerve, which we're now releasing and sort of releasing the tumor from the top down. And then of course, that's the nerve section close to rotundum there. we finished the palate cuts from below, all transorally, and delivered the specimen. So obviously our nerves, not surprisingly, V2 and Vidian, both positive. I tried to chase both of them as much as possible to get sort of clearance of that disease. Any comments on surgical approach?
John,
Yeah.
I think the time is up. If you want to have one last word before we have to finish the session.
Yeah, I'll just sort of invite one last comment on surgical approach from the group, or comments about how things, surgical approach and comments from the surgeons mainly. Dr. Crow, any thoughts?
No major comment. It's basically what I would have done. It's easily reconstructed with a radial forearm flap or a prosthesis, according to the preference of the patient or the surgeon.
Dr. Nikolai?
The same policy. Here, it's important the opinion of the patient. What we decide to do as a reconstruction is strictly related to the willingness of the patient to undergo a free flap or to go for an obturator, but the surgery would have been done exactly in the same way you did it. Excellent.
Yeah, and we did a radial forearm flap. Doctor, just to wrap up finally, Dr. Yu, tell us what you see on the imaging here.
Okay, so if you keep going back, go back, right there. So if you stop, go back another slide, so you can see the large reconstruction along the inferior aspects of the intertemporal fossa peripharyngeal space. And the thing that we're seeing here is enhancement and thickening of the left rotundum.
So you can certainly see here, right into enhancing nerve, right into Meckel's cave. We could have probably chased that a little bit more. And obviously in a 75-year-old, I weighed that option. We did chase it. We took some of the canal down and chased it. And at some point we have to decide when are we going to stop going here. And so this patient is sort of planned for adjuvant radiation. We chased the Vidian nerve. I couldn't see on the imaging. Any comments on the Vidian nerve, Dr. Yu?
No, I think you took it all. Like you took it right back to the
We took it right back to the carotid genu. Microscopically, both nerves obviously positive. The patient planned for adjuvant radiation. So I know we've run 5 minutes over. So I'm going to turn things back to Dr. Gibby, who has some closing comments.
Beautiful
Sure.
job.
Well, thank you all. This was one of the most distinguished panel I had the honor of participating. Thank you for joining us in our session. To the audience, thank you. These sessions are all recorded and you can watch them through the HNS website. Please encourage your trainees and your friends and give us feedback. We will be back on April 21st with our session on melanoma. We have only 5 more sessions left for the 2020-2021 academic year. Thank you all from New York City. Have a great night wherever you are. Take care.
Thank you so much. Bye-bye.
Thank you.
Everyone.
Great job.
Ciao.
Ciao.
Ciao.